Hello, Dentium viewers. Welcome to Dentium Live Surgery. I'm Dr. Byoung Kyou. It's a great honor to share my case with you today. Today's my surgery is placing an implant in a compromised extraction socket. Today's patient is a 65-year-old female. She came to my clinic for implant restoration due to discomfort in the area of tooth number 34. The tooth showed severe periodontitis with severe bone loss beyond the apex. This is a panoramic view. As you can see, there is a severe alveolar bone loss around the tooth number 34. And the soft tissue recession was not very severe, but post-discharge was observed. On CBCT view, we can see more than 7 mm of vertical bone loss. The buccal bone plate is completely lost. Only a very thin lingual plate remains. There is also severe bone loss in the medial-distal direction. Overall, this is a very compromised situation. It looks almost impossible for immediate implant placement. In these advanced periodontal destruction cases, immediate implant placement is very challenging. We cannot reliably predict how much gingivalization will occur after surgery, and also primary stability is difficult to achieve, and we cannot predict how much the graft material will reserve over time. But today, I will use the iGTR technique to cover the socket during the surgery. Traditionally, we were thought to remove all the granulation tissue after tooth extraction. However, nowadays, there are many reports suggesting that preserving the intra-socket granulation tissue can be beneficial in periodontal regenerative surgery. Many studies have shown that granulation tissue can be a source of mesenchymal stem cells, and that it also has excellent healing properties. Because of this, it can be used to help seal the extraction socket. So instead of removing the intra-socket granulation tissue, I carefully elevate it and reposition it over the socket entrance to cover the extraction socket. So I call this technique iGTR. I've been using this technique for ideology preservation for almost 10 years, and I have had many good clinical results. Nowadays, I also use this technique in immediate implant surgery. And in this case, I will be using the bright tissue level implant. The bright tissue level implant has a slim design while still maintaining high mechanical strength. So even with a narrower implant, we can preserve more space for the surrounding bone. As a result, even if some recession or graft resorption occurs later, the situation will maybe still be more favorable compared to the conventional implant. And for the bone graft, I will be using OSTEON Xeno. OSTEON Xeno is a bovine cancellous bone graft material. In general, xenografts are sintered at high temperature over 1000 degrees. But during this procedure, the microstructure can melt and become relatively smooth. However, OSTEON Xeno is manufactured using a relatively lower temperatures, lower sintering temperatures to minimize changes in the surface microstructure. Because of that, it is favorable for both new bone formation and volume stability. And if there is not enough granulation tissue inside the socket, we can also use collagen graft to seal the socket. Usually, many people use collagen membrane to cover the socket, but membrane mainly blocks soft tissue ingrowth. But collagen graft is not a membrane, it's a collagen matrix that helps soft tissue migration and healing, and also helps increase of soft tissue thickness. so it can be more favorable for socket sealing after extraction. Here is a similar case. The patient came to my clinic for the treatment of tooth number 35, and the tooth also shows severe periodontal destruction. On the CBCT view, you can see the buccal bone is missing here. For this case as well, I planned the immediate implant placement using bright tissue level implant. By using a slim but strong implant, we can preserve more buccal bone on the buccal side. After tooth extraction, I raised a full thickness flap, including the granulation tissue inside the socket. I started from the wrinkle side and reflected everything as one single flap. With this kind of full flap elevation, the surgical field is very clear. And 3.5 diameter bright tissue level implant was placed, and OSTEON Xeno graft was used for bone grafting. And digital abutment was then connected. After that, the flap was closed and sutured. Because of the granulation tissue from the bottom of the socket was elevated and flipped over the sockets, so a releasing incision was not necessary. This can help reduce patient discomfort. And this is right after the surgery, and the implant is placed nicely in the ridge. And 4 months later, I placed the final restoration. And as you see, we can see that the alveolar ridge has been well maintained here. And this is the panoramic view after the delivery of the final restoration. Although the periodontal tissue was severely compromised, this case could be managed simply using iGTR technique and bright tissue level implant. All right, let's just start today's surgery. All right. Now I'm using a forceps to remove tooth number 34. When you pull out a tooth, you should be careful not to hit the opposing tooth. So I sometimes place my finger to cover the opposing tooth. We are going to use the intrasocket granulation tissue. So now I will make an extra socket incision on the wrinkle side where there is a lot of hard tissue volume. So now I'm using number 15 blade to make the horizontal incision, and then I go to the proximal area. When you use this technique, you should be very careful not to cut the proximal area. So I usually use number 12 blade in circular incision. And then now I'm reflecting the flap with a serrated multicurate. With very cautious, and always keep the tip of the curette on the bone, not to tear the flap. A bit by bit, slowly. When we use this technique, the surgical field becomes very clear. We can get good surgical field. So even in a very challenging cases, we can still get good surgical field, and that makes the surgery much easier. And when I when I check the socket, the granulation tissue is not enough to cover the whole socket, so I will I'll be using the collagen graft material to seal the socket later. Now I'm checking the defect site with a depth gauge. I think I think the vertical bone nose is almost 7 millimeters. And I also checking the lingual plate. When you place implant in the mandibular jaw, the drill sometimes the drill goes through the lingual plate too. So I'm checking the lingual contour with my finger. And when you reflect the flap, the tip of the periosteal elevator should be on the bone only, not to damage the buccal flap. And now I'm using the initial drill. When you place immediate implant in a sloped extraction socket, it's very hard to maintain the insertion path because the drill tends to slip from the sloped extraction socket. So I'm trying to use my left index finger to maintain the path. And also we don't have enough bone, so to get the good primary stability, I will use one step smaller drill as a final drill. When we reflect the flap, we should be very cautious not to tear the flap. But my assistant is a beginner, so it looks quite dangerous now. And now I'm preparing the bright tissue level implant, but it takes some time. As I told you, my assistant is a beginner, so it takes some time. And I told my assistant not to uh, damage the soft tissue. Soft tissue. Sometimes the assistant focusing on suction too much, so sometimes they may damage the buccal flap with the suction. Now I'm placing a bright tissue level implant, 3.0 diameter, 11 length, with a very low speed, 30 RPM is enough for implant placement. And the stability looks quite good. And when I place implant, I consider the biologic widths. So when we use bright tissue level implant, the center of the white plastic cap should be at the level of a lingual flap line, and that is quite enough. And it's typically proper. As you see, the socket was very compromised socket, but with the placing narrow implant, we can leave more hard tissue on the buccal side. And the defect looks like a favorable defect. Now I'm telling my assistant not to touch the fixture surface with the elevator. And also I took a lot of photos during the surgery. So most of my surgery time is spending taking photos. Now I'm using the OSTEON Xeno graft. I just placed the Xeno graft bone graft materials, but I think it's too much. Now I'm taking another photo. Now I'm replacing the buccal flap. Whether the bone graft material is enough or not, I'm checking now. And now I'm removing some of the bone graft materials. When we use the granulation tissue, when we use intrasocket granulation tissue technique, it's very easy to recover the ridge because we just elevate the granulation tissue from the base of the socket to the top. So the negative architecture becomes the positive architecture. So we don't need the additional periosteal releasing incision. So it's very comfortable and helpful, and we can reduce the patient discomfort. And also it's very easy for clinicians too. Now I'm trimming with a scissor. I will place the collagen graft to cover the graft material. So I trimmed it in V shape. Also, we can use a membrane punch to make a hole in the middle of the center of the collagen graft. But I've lost it, so I'm using the tissue scissor. And now I'm taking another photo too. The surgery is almost over. In immediate implant placement cases, I prefer to use collagen graft because the collagen graft is not a membrane. It helps soft tissue ingrowth, and we can make the buccal flap thicker. So I prefer to use this one. Now I'm going to close the flap with a 50 nylon, 50 nylon. I start the suture from the base of the buccal flap to hold the collagen matrix, collagen graft. So the needle will go to the lingual surface of the lingual flap. Now I'm adjusting the needle and needle holder to easy to handle, for easy to handle. And now the needle goes to distal area from outside of the lingual flap to inside. And now from inside of the buccal flap to outside. And then making a knot, and that is membrane holding suture, and it's a kind of horizontal matrix suture. To release the flap tension, I prefer to use this suture techniques. And there are many people using very thin suture material like 6O or 7O. But I think 5O is enough for suturing in these cases, because the too thin 6O or 7O is too thin, so it easily tear. So I prefer to use 50 nylon. As you see, the 50 nylon has enough tensile strength for flap closure in these cases. And as you see, I didn't made any parietal releasing incision, but the flap is repositioned very well. It's almost done. I'm stirring the distal area. Now I'm making a note. We can see small amount of graft materials is outside the socket, but it's fine. If we have enough intrasocket granulation tissue, I don't use collagen graft, but in like this case, we don't have enough granulation tissue inside the socket. I prefer to use collagen matrix, like collagen graft, to seal the socket, and to also we can thicken the soft tissue volume. All right, we just finished today's surgery. Okay. Actually, this video was recorded several months ago, so today I will show the result of the surgery. Okay, this is right after the surgery, panoramic view, and I placed the 3.0 diameter by 11 lengths, and it was placed quite very nicely. And these are the clinical photos immediately after the surgery, and these are suture removal 2 weeks later. Even though the buccal bone was missing, the soft tissue volume has been well maintained, and there is no noticeable collapse of the buccal contour, and healing appears stable. And this is the post-operative CBCT view. The upper images are immediately after surgery, and we can see the implant is well covered by 30 millimeter of buccal bone on buccal side, and the lower images were taken 4 months later, and we can see increased radio opacity around the implant. And right here, if you see here, we can see the increased opacity. So this suggests good bone formation and progressive healing over time. At around 2 months after surgery, a digital abutment was connected. At 4 months, the final prosthesis was delivered. As you can see, even though there was essentially no buccal bone at the beginning, the soft tissue contour was maintained very well without significant collapse. I believe this demonstrates one of the major advantages of the technique used today. And these are the pre-operative and post-operative photo. If this case had been treated with a delayed approach, we would need a lot of GBL and close the flap. We probably would need releasing incision. That usually means more surgical trauma and more discomfort for the patient. But in this case, with the iGTR concept, bright tissue level implant and collagen graft, we could keep the procedure much simpler. We did it in one surgery. And interestingly, the soft tissue volume is even better than before the surgery. And I think this is probably due to the collagen graft. Okay, and let's have Q&A time. And here's a question. Did you use your additional membrane on the buccal side after bone grafting? A membrane can be helpful in preventing soft tissue ingrowth, migration into the grafted area from the buccal side. However, in this case, I used the collagen graft only collagen graft to protect the graft material while also increasing soft tissue thickness. Extraction sockets naturally have good healing potential, so strong barrier membranes like membranes are not necessary in these cases. All right. This could be the answer. And okay, that's all for today. And thank you very much for watching videos. And next live surgery will be Friday, June 5th, 7 p.m. Thank you very much. Enjoy the rest of your night. Thank you very much.